Hi, good afternoon, everybody. I'm Dr. Balamurali. I'm spine and neurosurgeon. I'm going to discuss with you today about the acute management of traumatic brain injury. Now, let me just go through some of the most key things that you need to understand in terms of brain injury management in the acute phase when the patient comes to the emergency. Now, the first thing is that we all know that the most common cause of brain injury or other motor vehicle accidents, usually two-wheeler or four-wheeler, fall from height, violence, and various other causes. The age and risk factors are usually between the age group of, the initial 5 to 9 when they are, the young kids are very naughty, they keep falling down. And the next group is between the age group of 20 to 24 years of age. And then you have the people who are elderly who have falls at home. Men are twice more chance of falling down than women. And people with alcohol, drug abuse, violence, contact sports, high-speed driving without seat belts, all these are risk factors. I mean, the reason why we have to understand that a head injury is very serious is because, you have a variety of problems that can happen based on the type of head injury, whether it's a mild head injury, it's a moderate head injury, or a severe head injury. So you can have memory loss and paralysis or death, epilepsy, infections, neural damage, language disorders, behavioral problems, emotional disturbances, concussions, and various other headaches and lifelong problems. Now, as you can see here, a head injury can be a mild head injury where you have a small scalp laceration, and then followed by that, there's some blood loss because the scalp is very rich in blood supply. Or you can have some kind of a significant laceration exposing the bone. Um, can you hear me? Is everything okay?
Yes, we are hearing you. Yes.
Okay, fine. I just hear some noise, so I just wondering there's some background noise. Fine. So then you can either develop an acute subdural, as you can see in this picture I've just drawn and shown you, where there is a like crescent shade of blood on the CT scan. And usually this is from arterial bleeding. You can have an extradural, which is like the shape as you can see is an a concave shape, which can cause significant midline. Or you can have a subdural, which is chronic blood. So, or you can have an intracerebral bleed, so that there can be confusions and bleeding inside the brain itself. So all these bleed can manifest in different ways. Here you can see, I don't think you can't see the audio, I guess, but you can see the video how we have opened the dura, and you can see that there is all this blood clot just sitting right on the surface of the brain. So today, what I want you all to learn is, as therapists, you need to know about the pathophysiology of the problem, about what is intracranial pressure, the anatomy, the various physiological parameters that we take care of in the initial phase, and also the clinical assessment and how do you classify and what are the treatments. So this is probably at the level of a very junior doctor, which I've tried to maintain, but also it's very important because some of you will be working in intensive care. You may be giving therapy for head injury patients in the acute phase. And so it's very important that you understand what is being done and when you should start mobilizing, sitting up, and the importance of various drugs that are being used. So the intracranial pressure is probably one of the most important factors. So intracranial pressure is normally between 6 to 15 millimeters of mercury. If there is any raise in intracranial pressure more than 20 or more than 5 minutes, that means there is a raised ICP. So how you can measure this? There are small probes that we sometimes put it in the brain and you connect it to a monitor. You can read the reading. Or sometimes there may be a drain inside the brain through the ventricle. So from that drain, we will connect it to a manometer or to the monitor, and through that we can measure this. So why is the intracranial pressure so important? Now, if you look at this theory or a concept which is called as Monro-Kelly doctrine. So these are two people who describe this. So if you look at the kind of the volume of the skull is like a closed room. So if, for example, It's like a room where you can accommodate 100 people. Suppose you add another 50 people more. Okay, you may tolerate. But if you had 200 people into that room, some people are going to die because they're going to be compressed and pressed and they're going to die. The same way, the composition in the brain is 80% is the brain tissue or neurons and neural cells, 10% is CSF, and 10% is blood. So this has to be constant. If any one of these increases, then there's a gradual increase in the curve. It is like you add a room of 100 people, you add 10 people, then you put another 10, then you put another 10. Up to 50 people, maybe it will tolerate. But beyond that, then somebody has to die. The same way, the pressure curves keeps on increasing gradually and gradually unto a stage when there is, the pressure is significantly high and causes severe damage. So the ICP does not rise until the initial compensatory mechanism. So till that certain phase, it does not raise. But then it goes up very steady and high, and that is very dangerous and it can cause death. The commonest thing, the blood is either contusion, the brain swelling, or there can be a big hematoma collection of about 50 ml, 20 ml of blood. All this will add to the pressure of the brain. And then gradually this raises. When the CSF pressure, CSF will become reduced, it will push the CSF out and it will cause raised intracranial pressure, and the brain will just swell up and cause severe problems. So now there is some mechanism called as cerebral autoregulation. So the brain is a very, a beautiful organ where the brain and the skull is designed in such a way that there is autoregulation of the blood flow. So when you are lying down position, the pressure is different. When you're in a sitting position is different. In a standing position is different. But throughout every phase of this, the brain's autoregulation works, and it helps to maintain a certain amount of blood flow to the brain. So that is why when you see elderly people, when they get up from a sitting position very quickly, then they may have this dizziness because their autoregulation as you get older reduces. So in order to have this, cerebral autoregulation, so you need to understand what is cerebral perfusion pressure, mean arterial pressure, and intracranial pressure. So these are three terms that will be commonly used in ICU. So the cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. So whatever the blood flow through the arterial pressure, the blood is growing through the brain, that is what controls the cerebral perfusion pressure. So that is how autoregulation happens. So if you look at this curve, there is a constant cerebral blood flow. When the blood pressure, the blood flow to the brain keeps on increasing, the cerebral blood flow is maintained despite the changes because of the autoregulation. But after a certain point, when the blood pressure keeps on increasing to the head in severe hypertension, then suddenly what happens? One of the blood vessels will just open up, it will bleed, and the cerebral perfusion pressure will go up. So this is very important to understand, because if the cerebral intracranial pressure is very high, then what happens is, the blood flow will start reducing. As the pressure inside the head is really, really high, then there's less and less blood going to the brain. If there is less blood going to the brain because the pressure in the head is so high, then the brain cells will start dying quickly. So there is more ischemia. So the brain wants blood. The brain wants glucose. So without glucose, the brain cannot function. And if there is no glucose going into the brain, because the pressure is high and the blood is not entering into the skull, then more and more cells will die, the brain will swell more and more, and death will eventually happen. So that is why we have to control the intracranial pressure, and that is the entire key of managing in the acute phase. So all drugs, all treatments, everything we do, everything is focused only at reducing the intracranial pressure inside the brain. Now, this is a complex mechanism that happens when you have an head injury. So there is a direct neural disruption. There is a sudden increase of cytotoxic edema. There is a hematoma. The CSF volume will keep increasing. There is a vasogenic edema. So all these mechanisms, because of the trauma to the brain, causes raised intracranial pressure. So you can classify head injuries into different ways, but I just want you to look at only the severity. So this is the commonest classification used, called mild, moderate, and severe. So mild is when the GCS is 14 to 15. Moderate is when the GCS is 9 to 13. Anything GCS below 8 is a severe head injury, which means they are in a semi-coma or going towards coma, they have to be in ICU, they have to be ventilated, and you have to take care of oxygenation to the brain. So history, it's very easy to identify, but if there is a loss of, after a fall, there is loss of consciousness, amnesia, they have a seizure, they have vomiting. So all of these things are towards the history. Examination, you will do a full neurological examination, Glasgow Coma Scale. I'm sure you all know how to calculate the Glasgow Coma Scale. You want to see the pupillary response, limb weakness, any evidence of injury or anything of that kind. And this is what the Glasgow Coma Scale is, which you all know. So the things that you need to identify, one is the pupillary signs. In the acute phase, what will happen is when the swelling in one side of the brain goes up, there is a unilateral dilatation of the pupils because the third nerve is compressed, and this causes enlargement of the pupil. This is a bad sign. If you find that one of the pupils is abnormally big and not reacting to light, that means that side there is a tentorial herniation. Then gradually the other side also will start becoming fixed, and bilaterally if it gets fixed and dilated, then obviously the patient means it's a serious problem, because you can see that the third nerve has a long course, and around the tentorium it will get compressed. Now there are some signs of skull fracture. Sometimes the head injury may not be severe, but the skull may be cracked, so they may have fluid leaking from the ear or nose. If anybody patient complains while you're doing therapy that there is fluid, clear fluid coming from the nose or from the brain or from the ears, you must think about a CSF rhinorrhea. So this is very serious because they may be skull-base fracture, or sometimes they can have a black eye, like a periorbital hematoma. It's called raccoon's eye, or they may have a small black spot behind their ears. It's called as a battle sign. So all these things are suggestive of a skull-base fracture. Now let us come to the treatment. So the treatment part of it, the first thing is we are going to think about ABC. Like in any other trauma, once the patient comes to hospital, the first thing is you're going to assess the airway, you're going to assess the breathing and the circulation. So by doing this, what you're doing is actually you're perfusing the brain. So the brain, the way the brain functions, it requires two very important things. One, it requires oxygen, otherwise neurons will die. Second is it needs glucose. The maximum amount of glucose that is required by any organ in the body is the brain. So if the brain does not have glucose, then obviously the brain cells are going to die. And how does glucose enter the brain? It enters through the blood flow, through the blood circulation. So if there is not enough blood going to the brain, then the patient will start feeling dizzy. That is why when they have diabetes and if they go into hypoglycemia, what they do is they faint, because there is no blood going to the brain and immediately they lose consciousness. Yeah. So very important, maintaining airway, especially if the GCS is less than 8. You want to secure the airway. You want to stabilize the cervical spine. And you want to make sure that you monitor the CO2. You will make sure that they are not in shock. Some of you had attended my talk last Tuesday about spinal cord injury, acute management. You would have realized that we discussed about spinal shock. So similarly, you need to be able to differentiate between an hypovolemic shock and as well as a spinal shock or a neural shock, neurogenic shock it is called. So make sure that the patient is not in an hypoxic state and not in shock. Avoid giving too much fluids, but at the same time you need to give adequate fluids. Remember that people who have a severe head injury, it is usually because of a significant mechanism of trauma. So they may be a fall from height or a high-speed injury, and these people are also likely to have other injuries like spine fractures. 40% people with severe head injury can have a cervical spine fracture, abdomen injury, visceral tear, liver injury, pneumothorax. They may be having a pelvic fracture. So you have to assess everything. You just cannot only treat the head injury and leave the others, because you have to adequately give them blood and fluids. So then once you do a neurological examination, GCS is say below 8 or the GCS is whatever it is, you immediately need to think about investigation. And the gold standard investigation is a CT scan, not an MRI scan. Because MRI scan will take about 40 minutes to do the entire brain. The patient cannot stay inside a scan in an acute state where they are not well for such a long time. An MRI scan is not going to add any value about the decision making for surgery. So don't put any patient through an MRI scan. MRI can be done later if necessary. So CT scan is what you need to do. So if you want to do a CT scan, immediately shift the patient. 10 to 15% incidence of significant intracranial hypertension, even in patients with normal CT. So some conditions which you will not find out on CT are like a diffuse axonal injury. So there is small petechial hemorrhages inside the brain which you cannot pick up on a CT, but they still be low GCS. But all you want to know is whether the brain is swollen, whether there is any blood, whether the CSF circulation is there any herniation, uncal herniation. So these are the things you will pick up on the CT scan. So once you do a CT scan, and if you find a blood clot, then the decision is, okay, does this patient need a surgery? If the GCS is low, if there is neurological deficit, if the pupils are unequal, and if patient has an acute subdural or an chronic subdural or an extradural, immediately the patient should go to surgery. The time period, really the golden hour, is 1 hour. So they call as the golden hour. So the outcome of severe head injury with an acute subdural or an extradural is best when you operate them within 1 hour. So that is why if you have a severe head injury, it is better to go to a center where you have a neurosurgeon and a CT scan. There is no point in going to a very close by small hospital, because you go to that hospital also, you're not going to have a CT scan, you're not going to have a neurosurgeon, everything is delayed, and you probably will lose the patient. Yeah. So now what you do is you will be thinking about how to manage the cerebral perfusion pressure. So we need to now, as I told you, we need to now think about the perfusion of blood to the brain, which is the cerebral perfusion pressure. So we need to identify what is the patient's blood pressure. Is the blood pressure adequate? You may have to raise the blood pressure so that you allow more blood to go to the brain in a patient with head injury. So very important is that the patient should not be hypoxic and they should not be low BP. If the BP is very low, then the blood flow will not go to the brain. So sometimes you may need to start the patient on noradrenaline or any vasopressins, and you want to push the blood pressure up. So once you press the mean arterial pressure, then automatically the cerebral perfusion pressure will raise. So you want to maintain an CPP of about 70 millimeters of mercury. And we saw that CPP is mean arterial pressure minus intracranial pressure. Now the next step is, once you get the BP, pulse, everything under control, and the patient is now shifted to intensive care, and imagine if this patient does not require an operation. So there is no blood clot, there's just a diffuse injury, there is contusion everywhere in the brain is swollen, the patient is unconscious, patient is intubated in a ventilator. So the things that you have to follow in the acute phase, one is to elevate the head. So you want to elevate the head by about 30 degrees. And by elevating the head by about 30 degrees, you reduce the intracranial pressure. So you remember we already discussed, if the intracranial pressure comes down, then the mean arterial pressure minus intracranial pressure will be the cerebral perfusion pressure. So the cerebral perfusion pressure, the blood flow to the brain will increase. So that is why keeping the head up 30 degrees always in a patient with an head injury will help. Yeah, so that's very important. Now the next thing is, you want to maintain the oxygenation. So you want to, the way to check the oxygenation, one is the pulse oximeter, but also you want to maintain an CO2, a carbon dioxide, partial pressure of carbon dioxide, by giving hyperventilation. So what happens is, by giving a mild hyperventilation, so the pathogenesis is that there is a cerebral vasodilatation. When you have more oxygen, when you have more CO2, and you hyperventilate. So when you hyperventilate, you're pushing out more CO2. When you push out more CO2, then you start increasing the cerebral vasodilatation. so more blood flow goes into the brain. So the ventilator settings the doctor will change so that they make the patient hyperventilate, and because of that, you will have more blood flow going to the brain. And so these are all the benefits that are there because of hyperventilation. Then you need to sedate the patient, because every time this patient is coughing, sneezing, moving in bed, with every little movement, the intracranial pressure will go up. So you want to maintain that intracranial pressure. So you sedate them. You give them, propofol or midazolam or any anesthetic agent, and you keep them completely sedated. And also give them analgesia, because pain is again a stimulation which will raise the blood pressure. You don't want sudden rise in blood pressure. You want the blood pressure to be higher up, but it should be smoothly up, and it should not go. There should not be sudden surge of blood pressure, because if you have a sudden surge of blood pressure, if there's a small amount of bleeding, it will become a big bleeding. So you want to do sedation. Then you want to paralyze. The reason to paralyze, once you paralyze, the patient will not move his hands and legs. So once he's not moving, then he will not cough, then he will not gag to the tube, he will not go and pull the tube out. The tube I meant is the endotracheal tube. He will not go and pull the nasogastric tube. So all of these things. So it's very important that in these patients, nutrition is very important, because when there is head injury, there is an excessive secretion of gastric fluids from within the brain. Sorry, gastric secretion within the stomach. So what will happen is that these patients can develop ulcer, if they are like that in ICU for a few days. So in order for that, you want to put an NG tube, and you want to start feeding these patients very quickly. So you feed them, within 24 hours after head injury. Once they are in ICU, you start feeding them. So then after that, you go to the next line of treatment, which is anti-seizure. So you also don't want these patients to get fits, because if you have a fit, what will happen? So when you have a fit, you have the jerks of the entire body, the blood pressure will go up, so there'll be more blood flow into the brain, and there'll be more bleeding. So the little bleeding will become a bigger bleeding. So you have to make sure that you give them anti-seizure medication and keep avoid any seizures. The risk of developing seizures is about nearly 40 to 50% in an acute head injury. Now, in a patient who has this severe head injury and has a raised intracranial pressure, there are a few options you can do. So what you can do is you can put in something called as an external ventricular drain, and you can drain their CSF. So you take off that little bit of ventricular fluid, you can just take it off the brain, and so that the ICP, the pressure inside the head, will drop. If the ICP still does not drop, then you have to probably the next step is you to start them on Mannitol. So what does Mannitol do? So Mannitol is a plasma expanding effect. It increases the viscosity and autoregulation. So it decreases the hematocrit, the blood viscosity. So it increases gradually the cerebral blood flow and the cerebral oxygen delivery. So if you put a Mannitol, you start Mannitol, the patient should be in a catheter. So that because Mannitol is also have a diuretic effect, and they will be they'll be producing more urine. It will remove all the fluid from the body. So you have to make sure that if anybody is on Mannitol, there must be a catheter. So this is what you do when starting them on Mannitol. So, the prolonged effect of Mannitol does have some side effects, but we don't need to discuss that in detail. Alternative to Mannitol, you can start them on a 3% normal saline. Now you started all these treatments for these patients, and you check their sodium levels, the serum osmolality level, you keep checking and make sure that you give them adequately. So the next step is, if they are refractory, suppose say you do all these treatments, your head is elevated, you've given them paralysis, you've given them sedation, the blood pressure is well maintained, you're giving Mannitol. Despite all these things, still the patient's intracranial pressure is still very high. Patient is not responding to treatment. Then we go to the second tier of therapy. So here the first option is something called as a surgical decompression. As I said, if this patient has a clot, he must have gone to theatre by now, and the clot must be removed. But here we are talking about patient who does not have a clot. So here what you can do. So for example, going back to this Monroe-Kelly doctrine again, I told you if there are 100 people inside a room, the room is comfortable. If you put another 150 people, and then more people are going to die. So brain cells are going to die. So all you can do is you can break open the one wall in that room. So you give more space. Same way, the brain is squashed within the skull. So what you do is you remove the skull. You remove a part of the skull and allow the brain to expand. So that is what we do by doing craniectomy. So we remove the part of the skull and we let it exposed. And that is what we sometimes do when we lost all options and lost all control. So you just, you try and remove this. Then the next thing is, so what it does is it's not a frequent option. Sometimes patients who need an decompressive craniectomy, you have to do it both sides, but the results are very poor. If somebody is requiring this, then he's not going to do very well. You can put them on hypothermia. So when I was training, 20 years back, we used to actually put them in a bathtub full of ice cubes. Because hypothermia is supposed to reduce, the significant benefit of that is it reduces the blood flow, it maintains the ICP, and it prevents any, aggressive blood supply into the brain, and it has better beneficial effects on the brain. So we give hypothermia. Currently, what we do, we put an NG tube, and through that NG tube, sometimes we give an ice cold lavage to reduce the core temperature of the body. So the body temperature must be low. There is some studies which have been done on the use of steroids. There was something called as a crash trial, where they tried corticosteroids, but really there is no major benefit. You should avoid using it in elderly patients. We already discussed about hyperventilation, and then we go into something called as a barbiturate coma. So barbiturate coma is where you put them in a deep sedation. So you run out of all options, and now the only option that you have is to put them in a deep coma for several days and just wait and hope that the brain slowly recovers. But once you come into the second tier, you obviously, the outcome of this patient is going to be bad because he's not responding to any of the normal treatments. So barbiturates, again, there's a last salvage options in severe head injury where they are refractory and where surgery is not an option. So these are all the things that we would do. And these are lots of newer trials and newer things that are available in the market. And there is so much research still going on in terms of what we can do. But in essence, I just want to summarize by telling you, I just wanted to tell you, just in summary, I want to tell you that head injury management is very very important for the outcome. If the outcome has to be good, then early management and very good management in a very good center is the key. Because if you look at the outcomes of people who have studied about the outcome of head injury compared to managing in a smaller hospital compared to managing in a much more bigger hospital, there's a huge significant difference in how it is managed. So the outcomes are better in centers where you have people with spinal, neurosurgeon is available. You have a big team. You have MRI scans. You have CT scans. The outcomes are significantly better in those centers compared to centers where there is not much of facilities or there is no full-time neurosurgeon. Again, the care in an acute hospital, it has to be protocol managed. So you cannot straight away go and put a patient with an head injury immediately into coma. You cannot take a patient straight away into theater. You need to know the timing. Okay, how do you go step by step? So first you want to start on medical management, then decide whether surgery is appropriate, and then you manage controlled seizures. Then you want to control paralysis, make sure they're not moving. Then you have to take care of all other measures to avoid complications. You want to do regular bed turns. You want to maintain their head elevation. How long, we don't know it's going to take for them to be on a ventilator. So all these things are so vital in management of head injury. Now coming to some of the problems as rehab people, like physiotherapist or occupational therapist, what you will be doing in the initial phase. So I will give you a little small introduction to that, and Dr. Karthikeyan then will take on and talk to you about what are the things that you do in starting from intensive care to the first few weeks to the month after an acute spinal head injury. What are the treatments that you will take? So the first important thing is you have to rule out and make sure that there is no other injury. So, for example, you make sure you rule out an C1, C2 or cervical spine injury. Then you need to make sure that you rule out that there is no other long bone fractures and all other things. Whether the patient is, what are the comorbidities of patients? In patients with head injury, if they are diabetic, hypertensive, they can have so many other problems that can happen. So you want to rule out all of that. So once you ruled out all of that, then you start with some passive rehabilitation. You start with passive mobilization, passive movements, bed turns. You want to think about a TED stockings for their legs or a floatron pump, and then you want to look into and see what exactly are the other problems that the patient is facing. Why is the patient not waking up? Is this a diffuse spine injury? Is there a brainstem injury? Is there a difficulty in swallowing with this patient have? And then the recovery will slowly happen. The other thing I also want to mention to you is about what are the acute disabilities and what are the chronic disabilities these patients will have. So the acute phase is, yes, the patient is immobile in bed and can develop so many complications from chest, DVTs, seizures. They can develop peptic ulcer, because as I said, in head injury patients, they can develop peptic ulcer, and all of these things they can develop infections. So they are very highly prone to pneumonia, chest infection, and other UTI and other infections. In the chronic problem, so apart from their cognitive problem, their speech problem, epilepsy and seizures, if they have a CSF rhinorrhea, it may need repair, may need long-time bed rest. They may have significant cerebral autoregulation problems. So they may have problems, while tilting, putting them on a tilting table, or you may develop various other problems at that point. So these are all the things in the later phase. So what I would suggest now is probably Dr. Karthikeyan, you can take over now, and you can talk about in ICU what are the managements and treatments that you would do. And then, maybe if there are any more questions, I'll keep following up the questions and I can discuss about those questions. Is it okay?
Okay, fine. Yes. There is one question.
Yeah.
I think you can, there is only one question as of now. What are the clinical signs of increased intracranial pressure?
Okay, yeah. So that's a very good question. So if you look, there are two parameters that we need to look into. Number one is the clinical parameters, and number two is the monitoring and other parameters. So in terms of clinical parameters, when somebody has high intracranial pressure, the first thing is their conscious level will be reduced. So if anybody who is GCS is less than 8, they definitely have a raised intracranial pressure if it is head injury related. Second thing is pupillary signs. So they may have an unequal pupils. Usually it is one side dilated pupil. Next thing is they may have a sixth nerve palsy. Some patients have, because sixth nerve has a long course, and they may have a sixth nerve palsy. Then next thing is they may have severe headache and projectile vomiting. So they may have some vomiting and low conscious level. Headache is usually a very prominent symptom, that they have a severe headache. The next thing is the other non-clinical parameters that you would look for is if the patient has a very high blood pressure. Yeah, so if the blood pressure is significantly high and they are tachycardic, you need to, and if they are in coma, you need to think about if their blood pressure is raised. Their pulse oximeter readings will be less, so they will be hypoxic, so the saturation will be also very low. So these are some of the features of raised intracranial pressure.
That's nice, sir. Thank you very much.
Thank you.
I think it was a very good presentation with a lot of photographs, illustrations. Just a minute. Let's see any other question. Okay, what One question, Dr. Bala.
Yeah.
What if the intracranial pressure varies throughout the day? How to schedule their PT, OT, or SLP sessions, speech and language pathology sessions?
Right. Okay.
Very
Yeah. So I think that's a very good question. So this intracranial pressure changes will be present in the first few days to weeks, and usually when the intracranial pressure is significantly high, you should not be doing any PT. You should not be mobilizing the patient. You cannot be moving the patient, because any movement, anything you do, your blood pressure is going to go up, and if your blood pressure starts going up, then the intracranial pressure is also going to go up. So you should avoid if there is an uncontrolled, and if the intracranial pressure is not being maintained well with all the drugs and all the treatments I told you, do not do any physiotherapy or occupational therapy, and definitely no speech and language sessions, because the minute you put in, yeah, and if the patient has a gag reflex present, the blood pressure is going to shoot up when he coughs. So at that stage, you should avoid. But once if your patient is out of that acute phase, and if the ICP is labile, so in the case, in that situation, sometimes in the morning the ICP will go up, then it will be down, then it will be going up. So you need to assess and see how the patient is as you do the therapy. If you find that when you're doing the therapy, a certain maneuver, whatever you're doing, the ICP goes up, you should stop doing it. Yeah, so that is how you have to try. So that is how you have to schedule, and usually they follow a pattern. When you do certain activities like give some chest physiotherapy, they may be fine. But when you move the patient, when you sit him up, the ICP may go up. So you probably can't do that. I think for these questions, you really have to be guided by either your intensive care doctor, your anesthetist, or your neurosurgeon who is in that patient, because it will vary from patient to patient, age, and it will vary from, for every patient it will be very different.
That's nice. Very good. Thank you. And there is one question. Is there any first aid for brain injury?
First aid for brain injury? Yeah.
Yes.
I think the first aid is basically if you witness an say a head injury on the roadside, the first aid you want to make sure is, please do not try to splash water on their face. Please do not try to wake them up and shake them. Don't take them in an auto or your own vehicle and rush to hospital. As I said, patients who are in coma, who have an head injury, you should have a very high index of suspicion of spine injury as well. If it is, say, patient is awake, patient is conscious, and he's only probably lost a few minutes of consciousness, but then the patient is alert and he's looking around, and if he's fine, and if he does not complain of any pain in his neck, back, and he's sitting up or anything, then main thing is make sure there's no scalp bleeding. Immediately take that patient to the nearest hospital if he is conscious. If he's unconscious, as I already told you, no point in taking him to a tiny hospital unless you want to give initial aid. Take him, call an ambulance, and directly take him to a government hospital or private hospital or wherever you want to take him, but take him to a bigger center where there is a CT scan and a neurosurgeon if the patient is unconscious. So the first aid is just simple, airway, breathing, circulation. Make sure the patient is breathing, make sure he is conscious, make sure you stop any scalp hematoma. The easiest way to stop scalp hematomas, if there's any shop nearby or anything nearby, get some ice cubes, wrap the ice cubes in some cloth and just put pressure on the head and hold it tight. That is all that you have to do, nothing else. And then after that, once he goes to hospital, they will do the rest.
Okay, that's fine. Thank you. And the other question is, does going by the protocol of head injury management also mean treating the patient according to the RLA stages, that is Ranco's Los Amigos stages?
Okay. So
Yes, actually
you can answer that. What is RLA stages?
RLA is Ranco's Los Amigos. That is how we classify the vegetative state, coma state, and minimally conscious state.
Right.
So that is so. Of course, we use the evaluation of the head injury. We categorize the patient as per the RLA staging. Okay. in the head injury management, the RLA staging has a role in it, but there are many other parameters basically which really matters for the head injury management. Definitely, RLA stage has a role in the protocol of head injury management. And there is another question. Your views on multimodal stimulation for these patients, how long to provide, duration in a session, what kind of responses to be expected. I interpret this as the coma stimulation therapy, where we use the multimodal stimulation like olfactory, gustatory, then proprioceptive. So there is no what is a ready-made protocol as such, how long to give, what is the response of the patient. So how long to provide is, I would say that, I mean, I do not, I interpret that how many sessions or how long in a session. So I would say that in a coma stimulation therapy per session, we can make it as 20 to 30 minutes. See to that the patient, it is better not to have any sort of untoward autonomic responses rather than, even if the patient is not responding, that is on one side. But the patient, when you stimulate, he should not land up with any autonomic dysreflexia. So in a session, we can go for 20 to 30 minutes. But I would say not to irritate the patient, landing to autonomic dysreflexia. And what is the duration of coma stimulation therapy? That we cannot decide. It is, you have to keep going until the patient shows some sort of positive responses. So that is what kind of responses to be expected. The responses are basically, we can categorize based on the stimulation what we get. So, for example, if we show a light, stimulation, or patient with the motor stimulation movements, when he shows a positive facial grimace or a slightest of facial, the voluntary motor movements, even involuntary movements, that is a positive response. So the response base is based on the type of stimulation what we are giving. So that can be that can be categorized based on the stimulus what we are giving. And then another question is, how sure we can say that the response obtained from the patient is to the stimulus given? How sure can we say that the response obtained from the patient is to the, if the response is subsequent to your stimulus, then we can take it. So there is no any objective test or evaluation that whether it is involuntary or the response to your stimulus. But when the stimulus, if it is positive or negative, when it is subsequent to your, the effect response is subsequent to your stimulus, then we can take it as the response from the patient. Sir, can patient with head injury experience hyperreflexia? Because that is an important complication SCA when we try to recline the patient. Basically, the hyperreflexia or exaggerated tendon reflexes is a sign of upper motor neuron lesion. Whether it is, in fact, even in, I would say that the spinal cord injury, at the level of the lesion it is UMN, and above the level it is, at the level it is LMN, and below it is UMN. So the hyperreflexia or exaggerated deep tendon reflexes are the clinical sign of a UMN lesion, whether it is a brain injury or a spinal cord injury. So yes, I would say that the head injury will have hyperreflexia with associated exaggerated deep tendon reflexes, provided initially they will be in the flaccid stage. As you all know, in the Brunstorm stages of motor recovery, initially they will be in the flaccid stage, and slowly as the spasticity sets in, the hyperreflexia will present.
So the next two questions, maybe I will just answer briefly, and then you can also answer. Is about what the maximum level of independence a patient with severe head injury can obtain, and a similar question on what basis do we decide the prognosis in such cases. Now, If you look at the outcomes of severe head injury, so severe head injury meaning patients with GCS less than 8 at presentation or within the first few hours. So these patients, their outcome is generally quite bad, but younger patients do much better than older patients. And also it depends on the type of head injury, which is the pathology of the head injury, whether it's an surgical lesion or it's a diffuse axonal injury, and all these things. So if you want to kind of decide on the prognosis of these patients, so you need to understand that there are so many scales which have been identified to study this. And one of the commonly used as neurosurgeons we use is the Glasgow outcome score. So GOS score. So the Glasgow outcome score, I don't want to go in detail. You can always go and read it up. So this score gives you an idea about, what is the patient's clinical response, how is he improving, whether he's in a vegetative state, what is his GCS, what is his functional outcome. So you can use this GOS and you can see how it goes. But it is very difficult for anybody to say what is the maximum level of independence a patient. I have seen people with GCS 8 who have become completely normal with very minor cognitive symptoms. I've also seen people who have severe head injury who are bedbound for about 4 to 5 years. So the spectrum is very varied. It all depends on a few factors, and I'll probably narrow it down to maybe 4 or 5 factors. The number one is the time of presentation to hospital. So if an head injury comes to hospital within 1 hour, and if he started on treatment very early and the appropriate right treatment, the outcome is generally good. Younger patients who have a surgical lesion like an extradural or a subdural, which can be operated, they probably tend to do much more better than patients who have a diffuse injury or patients who have brainstem injury. So they again don't do very well. Then the next thing is about the protocolized ICP management. So if the ICP is properly managed, according to protocol, strictly, monitoring that very closely and keeping the penumbrum. So, I don't know whether you spoke about penumbrum in the stroke session. So if you want to try this, the same happens with head injury. So, you have the surrounding edematous brain. If you're not well perfusing, well oxygenating, if you're not watching the ICP very closely together, and if you're not allowing more cells to die, the outcome is better. So these are some of the factors, and they should not develop any complications as they go along, whether it is a bed sore related or infection related or seizures. So if you manage all this by protocol in a good center, the outcomes are far better than doing it in a smaller center. You want to add any more points to that?
Yes, as the outcome scales, there are some few other scales. You have made it very extensively. That is very nice. I have to add few other scales like any PTODs already they'll be using, like FIM score, functional independence score, modified Barthel index. These are all the scores they can use. How far their social reintegration is happening, and overall we have quality of life score as SF36, short form of QOL, quality of life 36 is there. So these are all the few other scales they can use for their functional independence after the traumatic brain injury. And I think the next question you have answered. Then how to deal with aggressive patients, especially patients with diffuse axonal injury. So this is one question.
Yeah. So it's a very difficult question to answer. I mean, and normally if a patient is very aggressive, we'll call the physical and medical rehab consultant to manage that, or we'll call the PT and OTs to come and manage. So as a neurosurgeon, I tell you the best way to manage patients who are aggressive, one, they need to be isolated because they really disturb in an acute setup I'm talking about. The other patients, there is no role for sedation or antipsychotic medication in the initial phase. Probably that is something you can think about, as you go along the treatment line. But more of awareness, talking, trying to make them understand, reassuring them, counseling, psychological therapy. These are some of the therapies. this is what I will do, but I think Dr. Karthi will be able to answer that better.
How to deal with aggressive patients, especially patients with diffuse axonal injury. Aggressive patients, when usually what we practically do is we discuss with the psychiatrist or neurosurgeon, is there any antipsychotics or sedatives can be used. So we discuss with them. So if it cannot be used, then physical, physically we have to make them, to get controlled. What we use is just boxes. We make, the with the hand they
Boxing
can
gloves.
plug out.
Boxing gloves.
Huh?
Boxing.
Boxing glove.
Yeah.
Yes, boxing glove. We make the boxing gloves for both the hands so that they don't pull out anything, and we can make a soft tie with the bed. So that is what we can do. So until they get controlled, and if there is no role for sedatives or antipsychotics,
Yeah.
is it
No,
necessary?
I think that's very important. Sometimes it looks terrible when you strap patients to the bed. I really don't like it, but that's something that you may have to do to restrain the patient. If you are abroad, you have to actually go and get a court order if you want to restrain a patient. So it cannot be an easy decision. You just cannot tie up patients in the bed. But that is one way, because they will self-harm themselves. They don't know that they are self-harming. So I think this has to be a combined decision with the family of the patient, the neurosurgeon, and the psychiatrist. What medications we can keep them to calm. Another question I think which I'll answer is about: is it necessary to replace the back of the skull? So when you do a craniotomy, we remove the skull, especially when you do a craniectomy, where we take off the skull and keep it outside. It is more of a cosmetic thing in the initial stages. So, till the patient is recovering well and the patient is doing quite okay, we tend not to put the skull back, because that involves another operation. The patient may deteriorate further. But yes, the answer to your question is, in 80 to 90% of patients, we must put the skull back, because otherwise the underlying brain, especially if the patient falls down or something, they can injure, because this brain is not protected. So yes, you should put the skull back. Very rare occasions we will leave it, but otherwise you have to put it back.
Is there any synthetic?
Yes, yes.
What are the options
Yeah,
that
there's
is
a lot
there?
of options are there. We have acrylic. We can put an stainless steel mesh. We can put titanium mesh, and there are much more newer products. We do a 3D scan. We exactly map the skull how it is, and sometimes these are all imported. All you have to do is do a CT scan and send the images to them. They will design the skull and they'll send it back to you. You just fit it back and put 4 screws. It's a very simple operation. What we do normally is we actually take the patient's own bone. We sometimes keep it in their abdomen, not inside the abdomen, but on the abdominal wall. Or sometimes we even keep it and store it in the fridge for, if it is for 3 months. More than 3 months, it will become mushy and it will break.
Okay, fine. That's nice. Then complete vision loss after traumatic brain injury. How to proceed with the treatment plan with them? No other problems with speech, swallowing, movement complaints, etc.
So this really you have to answer.
Okay, right. So make sure that the vision loss is there any chances for coming back? So you can do complete ophthalmic examination, and then with the light stimulus through the eyes, you can do a functional MRI. So make sure that, try explore all the possibilities whether the vision can be recovered by any means. If not, then we have to rehabilitate as a person with visually impaired. That's it.
Yeah, I think I have in my own experience seen 2 patients I can remember
Yes.
who completely lost their vision. Rehab is very difficult for them. But you probably have to also involve, teaching them braille, how to
Yes.
use, to identify commands. But there is no speech or language issues, then it makes it easier. But if they have speech and language issues as well, then things do become a little bit more tough. Hmm?
Yes.
So I think that's what it is.
These guys, once they were having normal vision, and after some time there is a vision loss, there will be a lot of psychological issues with them. So a person who is blind or visually impaired since their birth, it is easy to train them. But at one point of time, after having a normal vision for quite some time in their life, and suddenly if they are losing their vision, we have to cope up with their psychological issues, along with training them with braille and all other rehab plans for any other visually impaired person. And there
There's
is
a
another.
question about burr holes. Are they done nowadays? Of course, that is what we do all the time. The burr holes are done. I'll tell you, there's a confusion among people about burr hole and craniotomy and what is the indication. Let me just give you a simple example. Just take an example of a coconut. Yeah, you have a coconut. If you want to drink the coconut water, what do you need to do? You don't need to split the coconut into two. You need to make a small hole. Yeah, and the coconut water will come out. When will the coconut water come out? Why will it come out? Because there is a hole, and through that put a straw and you can suck the water out. But if you want to take the coconut actually, can you take it out through that small hole? No, you cannot take it out. Yeah. So if you have chronic blood, so where the blood becomes liquid, then you can put a burr hole and then you can take out that blood. But in an acute situation, the blood is a clotted blood. It is like the coconut. So to take the coconut, you have to split the coconut, and only then you can take it out. So this is the example between doing a craniotomy and a burr hole. So in an acute phase, there is no role for burr hole, because through the burr hole you cannot take out anything. You can only suck out the blood and a little bit of that fluid. So I hope that explains the answer.
That's right. This coconut, the coconut example, I think I can use it. Hope there is no copyright for that.
No, you can use it. I just
It's
made
very
it up.
good. That is very nice. Easy to convey the whole concept of craniotomy and craniectomy. Very nice. That's nice. And then, is there any other question? No. Fine. I think Dr. Bala made it very nice. Even he has covered a lot of rehab aspects also, though he's a neurosurgeon. He's a neurosurgeon with a lot of knowledge about rehab medicine. It is a very rare breed where we can see. It's very nice. And again, I would recapitulate that what is the role of the rehab team in case of a brain injury is, once the acute management is done, whether it is through surgery or a conservative, and when they are in the intensive care, make sure that their vitals are normal, they are properly positioned. Like as Dr. Bala told, the patient has to be tilted with 30 degrees head end. One is to prevent to make sure that the cerebral perfusion is adequate, and there is no chances of aspiration. Make sure that every gadget like the bladder catheter, NGT, tracheostomy, if it is there, if it is in position. So make sure that everything is intact. And always I would say the rehab plan is prevent complication and improve the potential. These two is the two ways where we have to work on that. So as it was mentioned, what are all the complications that we can have in a patient with brain injury is, initially the person will be flaccid, and during the flaccid stage there is a chance of subluxation of shoulder. Most of the time it is missed. Make sure that the shoulder is splintered with there is a proper support is given to the shoulder to prevent subluxation. A chronic subluxation can cause a brachial plexus injury, which has to be in mind. So try to know all the complications which has to be prevented, starting from musculoskeletal, that is flaccidity to spasticity, contractures, deformities, and then shoulder subluxation. And in case of respiratory system, it is hypostatic pneumonia. In case of bladder, it is cystitis, bladder infection, cystitis, bladder stones. And then in case of cardiovascular, most of the time this part is being undernoted, because I would say that once the patient's vitals are stable and the GCS is improved to an extent, try to take the patient out of the bed to prevent all the complications because of deconditioning. So all these things we have to have in mind. And once the flaccidity is slowly going away and the spasticity is setting in as per the Brunstrom's motor recovery staging, carefully observe the synergy patterns. We have to, as you all know, flexor and extensor synergy patterns. Use the appropriate exercise protocols, like whether it is Bobath or Brunstrom or neurolinguistic. All these exercise protocols, uh, neurostimulation, proprioceptive neurostimulation, all these things, and slowly make sure that the functional training is being implemented, starting from bed mobility to transfer from bed to wheelchair and wheelchair to standing and walking. So all these things are very important, to starting from the acute management to the social reintegration. So this is what I have to emphasize. And basically, rehab management is a team work, which includes the physiotherapists, occupational therapists, speech and language pathologists, psychologists, then dietitian. So all these people should work as a team, and make sure that the patient is having a best prognosis, leading to a better social integration. This is what I have to emphasize for all our rehab team. Thank you.
Thank you. I think that was quite a nice session, and I've learned a lot from the questions that have been asked. And I think it's very important, as you mentioned. It's a combined effect. The initial part of the acute care only brings the patient back to life. And if the care is proper in the acute phase, you avoid complications. But this is a lifelong disease. And thanks for Dr. Karthikeyan, who mentioned that I have an interest in rehab. And I think I've developed this interest after I returned to India from abroad, after 15 years, where rehab people have a very important role in getting this acute injury into a meaningful, useful person in the community. And that can only be done in the chronic phase. So once you come out of the hospital, and if you're going to have a combination of cognitive, psychological, physical, and various other problems, all these have to be addressed. And especially in our community, in our kind of setup in India, patients' awareness is very minimal. So really, you therapists have a major role in educating them and doing the appropriate treatment, and it should be very systematic, and it should be an evidence-based practice that you need to try and see what is the best outcome you can give in order to make that person, integrate them into the community, and make them useful citizens, where they are able to get into a job, they're able to earn, they're able to go back to a reasonable lifestyle. And the family, they are so worried and they have false hopes. We have in our center quite a lot of patients with traumatic brain injury, where the initial surgeon or the acute team have said in 3 to 6 months he'll be fine, but he's now nearly 7-8 months down the line, and he's still he's not doing anything. He's bedbound with lots of significant cognitive. So the patients the attenders keep wondering, the family, the doctor told that he'll be better in 3 months. He's now 7 months, 8 months down the line. He's still not good. What's happening? Why is there a problem? Do we do scans? Do we do this? So I think as therapists, you have to be realistic. Head injury and stroke are not very forgiving. It is not like a spinal cord injury where you can actually, do quite a lot of things to get them back to a good, reasonable activity, because, it's like, the level of injury, and for this level, that majority of patients can do well. But head injury is not like that. Proper assessment, proper therapy is very essential to try and get them onto that board. So thank you very much. We are going to start a whole series of these lectures and discussions, and I hope that you will all benefit from this, and you can always be in touch with us. We will be announcing very shortly about all our various teaching initiatives, and we will be bringing in a lot of faculty from all over the world to do these webinars related to rehab, which is going to be of benefit to the physiotherapy and occupational therapists, speech and language pathologists, to all of you. Thank you very much. And thank you, Dr. Karthikeyan, for organizing this.
Thank you so much. Thanks to all the attendees who patiently listened our webinar, and we'll be coming up with many interesting sessions soon. Thank you very much. Thank you, Dr. Bala.
Thank you.
Thank you.